Good afternoon to those here on the East Coast, and good morning to those on the West Coast. I'm Vikas Saini, president of the Lown Institute, and I'm delighted to kick off today's special event, the State of Medical Debt in the United States. So one housekeeping announcement before we begin. If you want to ask a question for our panelists, please use the Q&A function in Zoom webinar mode. That's a separate function. We'll have members of the staff monitoring that so we can get to as many questions as possible. So obviously we're here today because medical debt has become an epidemic in the United States with serious consequences for our physical health and our financial well-being. So when we're struggling with a health condition, or if we're in the middle of a medical emergency, the last thing we should be worrying about is the cost. And yet, we're constantly seeing examples of people avoiding necessary medical care because they're afraid to go into debt. Boston folks might remember back in 2018, a woman fell between the subway platform and the train, and her leg got stuck in the gap. The cut on her thigh was so deep you could see the bone, but she pleaded with others not to call the ambulance because she couldn't afford the charges. So sadly, that fear of hers about going into debt is valid. Half of American adults have struggled with paying medical bills in the past 5 years. The burden of medical debt can force families into painful choices, like whether to buy groceries or whether to pay off that debt. And higher rates of medical debt have been tied to worse physical and mental health, and even higher mortality rates. But the good news is that this is an issue that's been getting increasing attention, and policymakers are starting to take action. We're seeing cities and states paying off medical debt for some patients and improving regulations around billing and collection practices. That's why we thought it'd be a perfect time for this conversation. So today we're going to try to discuss it all. How bad is medical debt in the US? What's causing it? And what do we need for transformative change in this area? We're going to have 4 panels lined up today, and we have amazing speakers ready to dive in. Our first panel will discuss the scope of the problem, and we're grateful to include a patient's very personal story. Then we'll have a panel on the drivers of medical debt to explore why it's so prevalent. Then we'll dive a little deeper into what we've learned in our research at the Lown Institute regarding billing and collection policies at over 1,000 hospitals in the country. And finally, we'll cap off today with a panel dedicated to discussing solutions. What are we currently seeing out there, and what else can we do to curb this epidemic? So before we turn to our first panel, we wanted to get the conversation going with a poll for all of you. So our first question of the day is, do you know someone personally who has struggled with medical debt? So you should see the poll question on the screen. So take a second to answer, and we'll reveal the results shortly. Hopefully, most of you know that over the past 5 years, we've been publishing the Lown Hospitals Index for Social Responsibility, which is the first hospital ranking to include metrics of health equity, value, alongside traditional outcomes measures. One of our most frequently requested metrics for the index has been around hospital financial assistance and medical debt. So we're happy to announce that we're just now doing that. We're getting that metric ready. With a grant from the Arnold Ventures Foundation, we've created a national database of the financial assistance and collection policies of thousands of hospitals. So we'll be sharing some of that research today, and you can view this data for 1,250 hospitals right now. We're happy to contribute to the ongoing discourse and provide important resources to policymakers and community groups who are working to reduce medical debt. So before we get to our panel, here are the results from the poll. Wow, 83% of you know someone, maybe it's you yourself, who struggled with medical debt. 17% do not. So I guess, we're a somewhat selected group. The topic is selected, so maybe we shouldn't be surprised when the prevalence is so high in the country. But that's phenomenal. All right. So let's see how that compares to national data with our first panel on the scope of medical debt. So please join me in welcoming our panelists. Noam Levey will be guiding this panel's conversation. He is the senior correspondent at KFF Health News, who's written over a dozen stories on medical debt as part of KFF's Diagnosis Debt series. Joining us also is Lisa Edmonds, former hospital chaplain at her local hospital in Greenville, South Carolina, and she'll be sharing her own story of dealing with medical debt. And with us also is Dr. Christopher Goodman, who is a practicing clinician and researcher, and is professor of internal medicine at the University of South Carolina. Noam, take it away.
Thanks so much, Vikas, and thank you to the Lown Institute for hosting this issue. As you mentioned, we've been covering the medical debt issue fairly extensively over the last few years, dozens probably of stories that we've pumped out. And I don't want to take too much of the time here so we can get to these two great speakers, but just to set the table a little bit, because you mentioned the extent of medical debt in this country, and I think it's just worth underscoring that the state of medical debt in America is grim. We found 100 million people in this country currently have some form of medical debt or dental debt. And if you go back and look further, it's more like 57% have had some healthcare debt in the last 5 years. So this is now no longer just a byproduct of our healthcare system. I would argue it is actually now a defining feature of the way healthcare works or doesn't work in this country. And of course, 100 million people means 100 million stories. And maybe that's a good way to jump into our first guest, Lisa Edmonds, who is somebody who has unfortunately, intimate experience with medical debt while she worked for a hospital system in South Carolina. Lisa, why don't you tell us a little bit, for starters, kind of about your experiences and how you managed to navigate them?
Thank you, Noam. Well, as it's been said, I worked for the hospital that I incurred my debt. I was the chaplain and patient advocate in the emergency department. However, I did face a situation that was so devastating in my life that I attempted suicide. I was in the hospital for nearly a month before I came home, still very ill and very fragile. And I happened to be at the place I am now. I have a large kitchen island that looks out over my backyard. It's a beautiful place. So that was where I opened up that very first bill as I arrived home, to the tune of over $200,000. I really didn't think a lot of it at that point. Again, I was sick, but I also just made the assumption that insurance hadn't paid anything. But as we moved into summer, I continued to get bills from the hospital with no indicator that insurance had paid. So that was when I contacted the insurance company, and they told me, well, they had paid. They had gotten the bill changed to reasonable and customary. And by the way, because it was self-harm, they wouldn't be paying anything additional. I was totally devastated. I've always lived below my means. I've been a good saver, a good investor, for one reason. So when I retired, I wouldn't be in debt. And here I was, retired and in debt that was greater than the cost of my first home. I went to work at this very island to try and get the debt reduced or totally forgiven. I did have quite a bit of knowledge from working in the hospital how things worked, which I don't know was a great help. I got to work making applications, and I continued, of course, to receive calls from the billing department as well as debt collectors throughout the United States. Over a year, I had applied and been denied 3 times for debt recovery. Each application, I would show how dire my financial situation was, as well as how my savings was going down. The next summer, though, I did see a huge difference in my debt. I would often look online at my accounts, and it had gone down to $17,000. Let me tell you, that was like going out and buying a candy bar compared to the 200K. I checked with them. They said it was true. But a week later, I got a call from a collection agency indicating that they had purchased the debt and I would now be paying them. At that point, all you can do is sit down and cry. So much of the time during that year, I had thought, why didn't they just let me die? Here I was faced with this debt that I knew I would have the rest of my life. I contacted a nonprofit group called $4 that advocates for people with medical debt, which they did for me. And on Friday, September 22nd, at almost 5 o'clock on the nose, I received a call from the financial aid department at the hospital. A woman, Denise, let me tell you, that's another name for an angel. She said that she had seen all of my applications. She thanked me for my diligence and my organization. And then she said, my debt's been 100% forgiven. I was a little hesitant on believing that after what I had been through before. That had been 18 months, almost to the day, since I had returned home from the hospital and opened that first bill. And now everything had changed. There's never been a sunnier day. It's now been 8 months and I have had no phone calls and I show a 0 balance. Believe me, I check my online account frequently just to make sure it's not reappeared. But I'm also very aware that I am strictly a number. You know, God's answered a lot of prayers for me, but I'm also aware that we don't always have prayers answered. So it's very important to me to tell my story in hopes that we will see a change in medical debt and also to be there for others who face the same issues. Thank you.
Thank you so much for that, Lisa. And I'm so happy that your story had a happy ending, but you had to endure basically 18 months of unbearable stress and anxiety over this. And 3 times you said you tried to get through the financial assistance system. If you had to sort of say what your takeaway from going through that experience is, how would you articulate that?
I first always thought that considering the reason for my being in the hospital, I was very fragile. And to be faced with the bill and continual calls, and I would explain my situation, which my finances had been frozen due to a divorce that was occurring, and I did not have access to money to pay. So even though they knew all this, I got calls at least once a week from the billing department as well as debt collectors. They were all very nice, but it's devastating to think you could lose your home, you could lose everything you have in your latter years.
And Chris, let me bring you into the conversation. You're a clinician, you're also a researcher, but first off, as a doctor who cares for sick people and sees them at their most vulnerable times, is Lisa's story is obviously maybe an extreme version, but I would expect that you come into contact every day with people who are trying to navigate the stress that comes with thinking about how much their care is going to cost.
Yeah, thanks, Noam, and Lisa, thanks for your story. You put it together so well, and I'm sure that's not easy to do with I'm sure the emotions still being right there under the surface too. And it's stories like Lisa that got me involved in this research in the first place. I've been in clinical practice for about 14 years now, and that entire time has been spent mostly at safety net hospitals, both inpatient and outpatient, and that's been in Atlanta and then now here in Columbia, South Carolina. And to work at a safety net hospital is to get exposed to a lot of folks, similar to Lisa, uninsured or underinsured, or potential, other kinds of financial or just life complications that make it difficult to manage all the billing and collections after the fact. And those stories really stick with you on the clinician side of this, and that's kind of what got me involved. And yeah, it's all too common, even in hospitals that should do better and even have a regulatory requirement to do better. And that's some of the work I've spent time on, is looking at tax-exempt hospitals and their charity care programs. And it sounds like this situation matched that. There was a charity care program set up that clearly wasn't working well and wasn't meeting you where you were at to help keep you connected into care and to mitigate this burden of debt.
This is actually a question sort of for both of you, because one of the things that I've observed covering this issue is the sort of unspeakable suffering that a system that is supposed to take care of people is meting out. And we've talked about, Lisa, you've talked about the stress, the worry. People worry about losing their homes. Some people really lose their homes. Some people drain their retirement accounts. Some people don't have enough food to put on the table. And yet this is a system, the healthcare system, that employs tens of thousands, millions of people across the country. I've not met many people, if any, who went into healthcare to drive people into debt. Lisa, you mentioned the people you dealt with were very nice. Do you think people just lost sight of kind of what they were doing to the people that they were supposed to be caring about?
I think jobs are very specifically designed, and I think they were doing their job within the limits and scope of what their job was. I certainly don't fault them. They were all very understanding of the situation I was in, but they have a job to do.
Chris, similar question for you. You're, by virtue of your speaking out and the research you're doing, you're shining a light back onto the institutions where you work and the colleagues with whom you work who are directly and indirectly responsible for this. What's the response you're getting, and what insight have you gained about kind of how complicit everybody is in doing this?
Well, I think that's why this work of the Lown Institute and others is so important in raising their profile. I think that it's all just gotten lost in the shuffle. We live in such a complex healthcare system, and individuals working across the healthcare system that individually probably good people probably don't want a story like Lisa's to happen, but here we are, and it did happen. And I think specifically for the uninsured, there's not been that powerful stakeholder at the table to make sure that as changes kind of happened along the way in our system, that they made sense and the system worked for everyone, regardless of their insurance status. And that's what we've been missing, and that's why this kind of conversation is so important.
We only have a couple minutes left before we have to kind of get on to the next panel here. But Chris, let me ask you just a quick follow-up to that. In the course of the work that you're doing, do you see a light bulb going off for people? Do you see a reluctance to sort of confront this? How would you characterize kind of your work's reception in the hospitals you work, in the medical circles you move in?
I think within the healthcare system, you could say, and the research community, and then even nationally and political and other sort of levels of advocacy, you're definitely seeing more of a conversation. You definitely, as you put it, maybe the light bulb's coming on that, we've got to do something. And of course, there's been a lot of action across the country on this in a lot of different ways. I see RP Debt mentioned in the chat. Of course, involved in communities across the country, and we'll hear from them later, I believe, and advocates all up and down the continuum trying to raise the profile, and states doing lots of different really interesting things to try to solve the problem. So yeah, I think we are at a different, hopefully a pivot point here, and seeing more of a focus and trying to really get down to brass tacks to solve the problem.
Lisa, let me ask the last question for you, and then I'll hand it back to Vikas. But if I don't think probably the CEO of the hospital where you went is on the line here, but if you had a message to that hospital leader, or a hospital leader anyway, about what you'd like to see change, what would it be?
I think they look at, of course, your financial situation from the past and not in the present. So everything they were looking at regarding my finances were considerably different than where I was at the moment this occurred. So I think there needs to be some way that they are looking at current situations rather than the situations from your tax forms a year ago or even 6 months ago.
Terrific. Well, I know we could go on for hours, but I have to pass this on, and we have so many other great panelists. So Vikas, let me hand it back to you, and thank Lisa and Chris for your time and your insights.
Thank you.
Great. Thank you to all of you for helping us get a quick snapshot of how medical debt can impact someone's life. So now, as we move into the discussion on the drivers of debt, we have another poll for the audience. So this one is, which do you think is the biggest driver of medical debt? You only get one choice, and it's on your screen now. So please vote, and then we'll see what those results are. But while you answer it, let's introduce our next panel. Joining us today are Sara Rosenbaum, Professor of Health Law and Policy at George Washington University, and Ruth Landé, VP of Provider Relations at Undue Medical Debt, formerly RIP Medical Debt. And Ruth was previously the VP of Patient Revenue at Memorial Sloan Kettering Hospital in New York. So the story we heard from Lisa illuminates several different aspects of what the drivers are of medical debt. So what did it bring up for you in terms of the drivers as you see them? Sara, why don't we start with you?
Thank you very much, Vikas. It's very nice to be here today. So I divide the world of medical debt into two basic bins. There's the actual medical debt, and then there is the anticipated medical debt. So the actual medical debt, obviously, is the debt that we heard about, where there is an unavoidable encounter with the healthcare system. There's an emergency, there's urgent care, there is something happens that simply takes you out of the realm of making a discretionary choice. To the extent that healthcare is discretionary, which of course is a separate topic, these are the kinds of situations where there is no choice, it just happens. But then there is the anticipated medical debt, which is the kind of medical debt that I think is actually dominant. And we just don't see it the same way. We don't talk about it the same way. And that is the debt that people avoid by not getting health care, which I think is is in some ways even the more nefarious problem, because with medical debt, I mean, the actual medical debt, there may be some strategies for reducing or eliminating your debt. With anticipated medical debt, you're just going to get sicker. So the numbers are really amazing. I mean, the numbers of people who experience anticipated medical debt are essentially, if you look at insured people, I mean, uninsured people, we can set to one side because everything is anticipated medical debt. There is no discretionary health care, maybe some for children, but if you talk to anybody like a community health center caring for adults, they simply will not use health care if they can't pay. But even in the insured population, I mean, you look at the numbers, on average, you're looking at 40% of people skipping care. You're looking at 50 to 60% reporting that the cost of healthcare and the delays that they experienced have actually had an impact on their health. A third of people with insurance are paying off bills. And so, and half of all insured people basically report that that they are finding healthcare hard to afford. So those things, though, that to me is the real silent problem in all of this. And nothing that we did, nothing in the community benefit reforms of the Affordable Care Act, nothing in the surprise medical bill amendments that Congress passed several years ago, which help a little bit with certain kinds of bills, deals with head-on with the problem of anticipated medical debt. And I think that is what is just so costly to the health of Americans.
Thank you. Thank you, Sara. So same question to you, Ruth, with regard to Lisa's story. A number of different angles emerge, but let me add as a secondary element, which is, given how prevalent medical debt is, and yet most people, including Lisa, have insurance, what's driving this? What's going on?
Yeah, exactly. I'm really pleased to be here too. And Lisa did such an amazing job of telling her story. And Sara took the words out of my mouth, in the sense that there's a lot of studies out there about how many people have medical debt. Is it 2 in 10 Americans, 3, 4, 5? It's a lot, but it is more than that. It is everybody who fears getting it, and it affects their behavior. Exactly. So the numbers are enormous. And exactly as you said, the thing about insurance is it's not some accident that insurance has increasingly over the last 20 years had more and more out of pocket, which makes it essentially useless in terms of what it hits you. It's actually by design. What is it? Noam says it's not a byproduct, it's a defining feature. So before the Affordable Care Act, before the surprise billing thing, all of which were good things, there was a federal legislation, 2003 MMA, that gave supports to this whole business of having a high out of pocket. And it was done by economists who believed that our system would be helped by people having that awful phrase, skin in the game. And they called it, consumer directed health plans was the early thing. And it has proliferated. We've created a structure to do that. And so thus, in fact, in the last few years, hospitals have seen the majority of their unpaid bills are for insured patients. You can really also see some of the impact of state laws trying to combat this. Earlier this year, KFF Peterson put out a great report, and there's been so many reports, but in February, I recommend this one on medical debt. It was based on census questions, and you could see not only who is getting medical debt more, people with disabilities, Black families, all exactly those sorts of things, but how it varies by state. And that's because some states have tried to take action to reduce out of pocket, so that places like Hawaii or California have a lot less medical debt than, and we all know this, places that have done the worst thing, which is not even expanding Medicaid. So all the different actions that people have done. If you reduce out of pocket, you prevent medical debt. So this is before you get into financial assistance or anything, and everybody benefits when you have health insurance that does not have significant out of pocket. You know, a $10 copay, fine, but nothing else. Everybody benefits, and hospitals are not put in the morally impossible position of both offering care to patients and then harming them by having to bill them amounts that they can't afford. It's just completely not what, and why the American Hospital Association has the same statement: don't make us bill patients. So it's by design, and that's why it's there.
So Ruth, let me just ask you in that regard, are you saying that you would favor almost abolishing deductibles?
Yes, and co-insurance. If I had a car, which I don't, I'm a New Yorker, right? I would print out bumper, I guess I could still do it, but print bumper stickers, ban co-insurance, ban deductibles, both of them. Co-insurance is just evil.
Right.
Yes, in order to make this system work, you know, there's a bunch of people paying, government or private payers, whatever. There's a bunch of providers, physicians, labs, whatever, everybody. Does anybody really care exactly what those amounts are? Take the patient out of the middle. Take the patient out.
Well, so, but there's a reason we have these high deductibles and co-insurance and the like. And, you know, I'm not going to get into a religious debate about the early 80s and market fundamentalism, but let me put it a different way. We're talking about drivers. One of the drivers of the move towards high deductibles and co-insurance was the price spiral. Anybody who gets into this, and you know, I spent 15 years as a country doctor before I came back here and started studying up on all this stuff. Anybody who looks into this history, people are talking about the way, you know, the price spiral of healthcare, like in 1975, 1980. So there was a reason a certain consensus emerged. At this point, I'd say it was an erroneous consensus, but a consensus emerged, and that had to do with the prices.
Yeah, and I think that it is now a changed consensus. There are probably still people who advocate for that, but I think most people have seen the destruction, have seen that not only do people not have healthcare that is perhaps not as necessary, that people are, as we're all saying, afraid of and not getting healthcare they need. So as one economist said recently on a Minnesota panel, not all economists are right. She was a healthcare economist saying it about her peers. You know, it wasn't the right solution. It's not what other countries, whether they're single payer or multi-payer, do. It adds so much cost to everybody. It destroys people's health. It drives a trust wedge in between the care providers and the patient that should not be there. So yeah, we could have a whole nother panel on other topics and how that got there, and I'm sure there'd be other really great people on that. But in terms of moving forward, that is what we need to, you know, there's a lot of fancy ways to do it. Bring down that pay. California recently, their silver plan on their exchange, no more deductibles on it, you know. Both New York and Minnesota have a Medicaid Plus called the Essential Plan, and now Oregon is doing it. There's wraparound things, there's banning junk plans. All of that stuff helps prevent medical debt.
Yeah. Well, I would put it to you that if we were to get rid of copays, deductibles, and all of that, which I would support for all the reasons you stated, there will be a problem, and the problem will be, you know, the overall cost of care. I think partly this move to shovel it onto the patient's back is really a way of avoiding the difficult issue of how do we structure prices and costs in American healthcare, setting aside the whole issue of utilization. But let's keep going. Let's talk a little bit about hospitals, because certainly, you know, if I were a hospital CEO, I would agree with you. I mean, we're being asked to do something almost impossible. You're telling us make it affordable, and you're designing these plans that have all these copays, and now we're left holding the bag because you can't get blood from a stone. There's only so much you can do. On the other hand, almost certainly that's a big driver of debt. So for someone like Lisa, who worked in a hospital for many years and who is aware that financial assistance is available, she had to apply multiple times before she was considered. I still don't quite understand what happened in the end. What was the magic that $4 implemented? But so what are some of the patterns that you would see in financial assistance of hospitals or collection policies? Are there patterns that really contribute to the debt? You worked in rev cycle management. Do you
I
have any
did,
thoughts? And then
both at
Sarah
Memorial
after
Sloan
that.
Kettering and Rochester Regional Health. Yeah. And yeah, I mean, why should she, just to start with Lisa, since we were also moved by her story, why should she have to fill out all these forms, right? She has always paid her bills and saved her money. And why should she have to? I mean, I think for a lot of Americans, they say, apply to charity care. Do you know what people think about applying for the word charity care? People do not want to do this. It's scary, some of these forms. They ask you about your assets. I mean, again, have $4 on. They've got all the stories because they do this work. But if you've got a truck and you need it and you're afraid that if you list your vehicles, they're going to be, you know, it's really impossible. So I think hospitals have had to catch up with the times. And so what they've been moving slowly more towards, if they can afford it, is presumptive tools. So the technology exists so that hospitals can, without patients filling out forms, and at Rochester Regional, where, you know, I worked last, was using these presumptive tools, you can just find out what people's income are and decide that they have financial assistance without asking them to fill out a form. Now, not all hospitals have been doing that. Some of them have only been doing it with their uninsured because they sort of haven't kept up with the times. And it's very obvious when somebody comes in without insurance that they're going to need help, right? But for the insured, they're not quite realizing that even though somebody comes in, they have a job, they're, you know, pretty well set up. By the time care is over, ongoing chronic care, they've lost their job, their circumstances have changed. You spent 6 to 8 months fighting the insurance for the payment, right? So, so yeah, hospitals are starting to look more and more. In fact, Oregon is requiring hospitals to use presumptive tools. I mean, it's not a straightforward solution because for your small rural hospital, you have to pay transaction costs to run all of those. So, I mean, I think ideally, $4, and I have talked about this, we really should have government provide income data. I mean, if you're going to require hospitals to do effective screening, and a lot of states are, and I think we would expect that, then you should at least provide the income data so that it's easier to do. But we at Undue have been writing a lot of papers you can read about presumptive tools, how you use them, how you can misuse them. Sometimes people are using something called propensity to pay. So again, going back to Lisa, she always paid her bills, right? So she's going to have a high propensity to pay because she always did. That doesn't mean that she can afford to now, just as she was describing. And so it's not an easy thing for a hospital to do this, but that's what the, you know, society is pushing for.
Yeah, well, you know, I hate to rain on that parade a little bit, but I just heard that there's a startup, private equity-backed startup in the credit card business that's using propensity to pay to screen patients up front to be offered medical credit cards. So
Yeah,
there's
no, it's
many
awful,
angles
right?
to this.
It's
So
criminal
Sarah,
to ever
sorry,
charge
Ruth,
people interest.
Sarah, Sarah, I just
yeah.
want to turn to you for a second and give you the floor. The question at the hospital level, are there like certain patterns or aspects of hospital financial assistance that we should be aware of that if we address those, the medical debt issue would be mitigated?
No, I can't think of anything that would mitigate the problem. I mean, I think what if you look again at this distinction between actual and anticipated medical debt. So clearly, for example, the federal regulatory changes in the Affordable Care Act were designed to curb certain kinds of what the law calls extraordinary actions, okay? An extraordinary action is turning matters over to a debt collection agency, trying to seize a home, trying to seize property, using what essentially, you know, we would call strong arm tactics, right, to recover on debt. But what hospitals, I think, bank on more than anything, and I don't mean this to disparage them so much, but it's just a fact of life, is that if they most of the medical debt problems, I assume happen in the emergency department for people who get care in the emergency department. In other words, it is extremely rare for people to be transferred to an inpatient bed. What they're getting is visits to the emergency department where they get a several $1,000 bill. They get the rack rate bill and they can't pay that bill. And what the hospital has succeeded at without engaging in extraordinary collection practices is that it'll be a cold day in July before the person comes back. The deterrent effect on people who face medical debt is I think the deeper problem here. So you can say to hospitals, don't do mob-like things, don't seize their homes, don't seize their cars. And that's good, but the fact that Congress had to legislate this in 2010, and of course it's in an IRS rule now, but it's really not enforced. They don't do any real enforcement around the community benefit obligation. The community benefit obligation doesn't apply to hospitals other than the ones that are tax exempt. And so I've always assumed that the real strategy behind poor communication, behind bad signage, behind everything is the theory, if you want to be really cynical, of the person ends up with a bill, it's probably going to be a long time before the person comes back. And again, I think that this is the side or the dimension of the problem that we don't talk about. And of course, it goes to the prior discussion with Ruth, this notion that healthcare is discretionary. There is so little healthcare that's discretionary. There is none for children, of course. And for adults, people do not, I happen to live in Northern Virginia. They're a big hospital system. People do not go to this hospital system to sit there and enjoy a Saturday afternoon.
Yep.
So,
One last question for you both. We only have a couple of minutes. Sara, our system is sort of famously fragmented in many ways. Do you think fragmentation itself drives debt, or are there aspects of fragmentation, if addressed, could mitigate debt?
Well, I think that because of fragmentation, people who do have access into the healthcare system, I mean, I think of myself, right? I have all the access to healthcare that I reasonably need. And what I face is ridiculous repeats of the same procedures because the system is not coordinated. So there's waste, to be sure. And I think that fragmentation, it creates so many problems on its own in terms of people just not being able to navigate. It adds another deterrent quality to healthcare.
Yeah. Ruth, last thoughts? We got a minute left.
Ooh, yeah. Well, I mean, I would just add those extraordinary collection actions, suing, all that. We all agree that's not even worth discussing, that those are should be off the table. The federal government has never banned them, but states are often doing so, and they are in the minority in terms of what healthcare providers do. The Next Guest panel, Community Service Society, they put out some great reports on New York. It's a minority of hospitals who do those actions, and they should not do so. And there has been a trend against it. But yeah, I think the fragmentation of the system, the fact that you get financial assistance and there's a long list of doctors at the hospital you didn't choose who don't participate. I mean, talk about mind-bogglingly confusing. And when you have no trust, you can't afford it, you can't understand it, the level of suspicion that we hear, it's not helpful for promulgating solutions. And we really need to come together and figure that solutions out, because certainly providers and patients are all being hurt by this pernicious system.
Yeah, thank you. Well, we've talked a lot. We could talk a lot more about what the drivers are, but let's see what our audience members thought. So high price of healthcare, underinsurance, those are the two that are the biggest. And then lack of insurance coverage, logically. And then after that, low wages, income inequality, something else, which I don't know what it was. It'll be in the chat. So, I think that's a pretty fair assessment. We have a wise crowd, the wisdom of the crowd here, as opposed to the madness of crowds. So this is for you, Ruth. Now we're taking some questions from the audience. Is there an existing framework that describes a taxonomy of medical debt, i.e. those from surprise bills, those from small debts for primary preventive care, acute, unplanned emergency, etc.?
Yeah, I mean, I'd turn to KFF, which is often the source of really good data. They did one, it came up with a study that showed the 4 out of 10. And they were smart enough to also ask about dental, because that's a big area. And also yet another sign that the idea of shopping around is going to really work so well. So it's a whole mix. It's every kind of care, but not so much primary because that's cheaper, but whether it's hospital-based, surgical, dental, labs, radiology, we see it spread out over all these categories. So it's all over the place. And I think people with chronic diseases, there's some studies to show they particularly suffer.
Yeah. And Sara, you've been talking about, you know, the two types as you see it. Is there a dominant kind of medical debt or a dominant driver? That's another question from the audience.
I think probably in terms of anticipated debt, I think it's probably routine health maintenance things that we all have that you know should be cared for, whether it's hypertension, whether it's depression, whether it's dental care, whether it's, you know, all the things that you hear over and over and over again are really important for you to manage and not let get serious. And if you talk to any healthcare provider who does see low-income patients, especially lower-income patients who just can't afford any care, I mean, they will tell you that the greatest tragedy is all of the routine care that their patients forego.
Indeed. Another question from the audience. This is actually, to me, quite interesting. And it gets into maybe the machinery of efforts to reduce the problem, or at least, you know, soften the blow a little bit. Maybe it's rhetorical. Can the uninsured get charity care more effectively than the underinsured?
Oh, I don't
mean,
think at all, because I think they just don't show up.
Well, that's true. I think totally, Sara, you're right. If they do show up, yes, the uninsured tend to get better assistance than the insured, just because it's clear right up front. You know, we'll help you get Medicaid if we're in a state where there's decent Medicaid, and then otherwise it's obvious. And so there is a study out of it's a place called was originally called Crow, now Kodiak. You can look at the trends in hospital bad debt. And in 2021 was the first year most of bad debt, meaning unpaid bills, were for the insured. It's been dramatically increasing. And it's because people those mechanisms within the hospitals have not been identifying the insured patients and their needs.
Well, you know, not to be too parochial about it, but certainly here in Massachusetts, where with the Romney Care, the progenitor of Obamacare, you know, we've had 98% coverage or something like that. And yet, you know, recent surveys have shown that with everybody with quote unquote good insurance, it's not so good. 40% of the population is really worried about medical bills. And
exactly. We need Hawaii, not Massachusetts. They ban those out of high out-of-pocket costs.
Yeah, I'll move to Hawaii for that. Yes. Well, let's move on. Thank you to both of you. This has been a good discussion. Clearly, we're just scratching the surface. We'd love to have a lot more time with each of you, but thank you.
Bye.
Bye.
Yeah.
Thanks.
So we've heard a bit about the role of hospitals in the cycle of medical debt. Clearly, this is a topic that needs more research, and fortunately, we have a little bit of it to share. So in this session, we'll talk about some recent projects and hospital policies related to billing and collections. First, let's welcome back Noam Levey and our own Paula Smith to join us. She's Senior Data Scientist at the Lown Institute. So before we hand over the mic to them to learn about these projects, we have another question for you in the poll. This is a bit of a trivia question. You should see a pop-up poll now. Take a look. Which of these may disqualify you for financial assistance at a real hospital in the United States? Owning a jet ski, having a prepaid funeral plan, receiving treatment for an eating disorder, not being a US citizen, or all of the above. So have at it. And we'll share those results in a bit. So Noam, you had a team of research assistants collect data on over 500 hospitals a couple of years ago. Can you describe that project for us? What were you hoping to learn? What motivated it?
Thanks, Vikas. So what we were trying to understand was some of what you've gotten at already in this discussion, which was this incredible variability in both financial assistance and the way that hospitals bill and collect, because there's been a fair amount of media coverage, I would say, over the years, identifying individual hospitals here and there that were suing their patients or doing some other nasty thing to their patients. And we wanted to sort of understand what is the landscape really look like. And to do that, of course, we had to get into the nitty gritty of the actual policies and practices of what we took a random sampling of about 500 hospitals, about a 10% sample all over the country. Big for-profits, big not-for-profits, critical access hospitals, public hospitals. And it was a gargantuan undertaking, as you have learned now that you've picked up the baton at Lown. The gray hair is partly from my daughters, but it's also partly from trying to extract all this information from 500 hospitals.
Right. And Paula, as the supervisor of our current team of research assistants, and as Noam said, we have picked up the baton. We've been doing this work, a very similar path as Noam. Can you describe for the audience what we've been doing here?
Yeah, of course. So our project is an expanded version of Noam's original study. The data is collected from policies publicly posted on hospital websites and subsequently confirmed with those hospitals. Our goal is to collect financial assistance and collections policies for 2,500 hospitals by spring of next year. And we currently have preliminary data for 1,250 available now. So this includes information on eligibility criteria for free or discounted care, help for large bills, and allowed collections actions, as in, does the hospital policy allow for suing patients, garnishing wages, denying non-emergency care, among other actions they can take.
Great. So a question to both of you. As you've done this work, how difficult is it to find those policy documents and then to interpret them? Noam,
Paula, you want to? Ridiculously difficult. I mean, finding them alone was a major undertaking at many of these hospitals. So some of the larger systems make it relatively easy if you know where to look. But even finding a financial assistance policy that delineates what the criteria are for qualifying for aid can be like looking for a needle in a haystack. Many places do not post this information on their website. Even if they do, sometimes you have to go through various other options, like how to enroll in a credit card before you can find out whether or not you would qualify for aid. And one huge loophole that we kept running into in the federal law is that the disclosure requirements around financial assistance and kind of collections activities that an institution can engage in, those standards only apply to not-for-profit hospitals. So there's no obligation by for-profit investor-owned facilities to disclose this information. And interestingly, there's no requirement on public institutions, public hospitals to do this. So you start by lopping off a large portion of the universe of hospitals that doesn't even make this stuff available by any rule.
Paula, I mean, are there instances where it's particularly easy, but are there any memorable instances where it was hard, the way Noam's been describing?
Yeah, there was one, shall remain unnamed, large hospital system that had taken all of their hospital policies and put it on a completely different website that wasn't accessible through the hospital websites. So we couldn't find it through the usual means. So it happens.
Can I make one additional observation about this? Because even if you can find this stuff, you need a law degree to understand a lot of what this stuff means. Under what circumstances do you qualify? if many places have geographic restrictions on where you qualify for aid, we're sort of have a long suffering story that I'm trying to finish about a patient in Florida who literally turned left at the intersection instead of right. And because of that fateful decision, she got stuck with $20,000 in medical debt, and she would have qualified for free care if she made the decision to turn the other way. And there would have been no way, looking at this hospital's website, to know that this geographic area she lived in was actually on the south side of the street rather than the north side, and therefore she didn't qualify.
Wow.
God help the patient trying to negotiate this.
Yeah. Paula, so when you do find these policies, are there any patterns or trends you're seeing?
Oh yeah, we see a lot of variation in our hospital policy data set. So we're going to show some examples from our preliminary findings. Most hospitals in our data set offer free care for patients that make between 200 and 249% of the federal poverty guidelines, or FPG. For a family of 3, that's between 52 to 65K. But there are also many hospitals in our data set that expand those limits and offer free care for patients at 400% FPG, which would cover a family of 3 making $104 a year. And on the other end of the spectrum, there are hospitals that grant eligibility to patients making only 150% FPG. That would be a family of 3 making just $38,000 a year. So let's walk through an example of a family of 3 making about $75,000, which is the median income in the United States. We'll cover 2 different options for this family: eligibility thresholds if they qualify for free care, and large bill requirements if they're not eligible for free care. So we can see differences in free care eligibility for this family, even among hospitals in the same city. Here's a map of Boston. At Beth Israel Deaconess Medical Center, our family of 3 could make up to $100,000 a year and still be eligible for free care. But just a few blocks down at Brigham and Women's, free care eligibility has a maximum of $38,000. So our example family would be making too much to qualify. Here's a similar map of San Francisco. At California Pacific Medical Center, Van Ness, our family of 3 could make up to $100,000 a year and still be eligible for free care as long as they're uninsured. While at Kaiser Permanente San Francisco Medical Center, free care eligibility ends at around $51K, regardless of health coverage status. Again, our example family making a median income of $75,000 would not qualify. For patients not eligible for free care, but who have a catastrophic medical event, hospitals may offer what they call support for large bills based on need. But how hospitals define the amount of a large bill is pretty variable. So let's use the example of the same family making $75,000 a year and now facing a medical emergency. At Medical North Hills in Fort Worth, a large bill for this family would be defined at $3,000. But at Texas Health Harris Methodist HEB, that bill would have to be $70,000 higher before it's considered a large bill, as the equivalent of the family's entire income for the year. Here's a similar example in Pennsylvania. At the University of Pittsburgh Medical Center Williamsport, a large bill for this family would be $11,000. But at Evangelical Community Hospital, that bill would have to be their entire annual income, $75,000, to be defined as a large bill.
Thanks, Paula, for those examples. I think they're very illuminating. Noam, are there any types of data you wish you could get, but you haven't been able to?
Well, so one thing which is obviously clear here is that the standards vary hugely. One thing that remains a black box is something that Lisa alluded to earlier, which is what actually happens to people when they come in and they try to get financial assistance, or they don't pay their bill and they're sued. And there's currently no reporting requirement for these institutions to report how many people applied for financial assistance, what percentage of those people got through the process, how much did the hospital provide, how much did they deny. And I think by putting some standards around reporting what is actually happening to patients, we'd learn a lot more about how hospital A is doing compared to hospital B. Right now, researchers have to sort of impute some of this using very imperfect data sources in terms of total charity care spending, which is in of itself problematic as a reported metric. And so I wish we could have gotten some of this, but even if a hospital had said they were willing to give it to us, I don't think they track this themselves, which is another part of the problem here.
Paula, any policies that stood out to you when you looked at them?
Sometimes we've come across some really specific details in a financial assistance policy. One hospital says in their policy that patients are not eligible for financial assistance if they drive their own vehicle without auto insurance. We've seen another where ownership of recreational vehicles like RVs or jet skis will bar a patient from financial assistance. So this shows like how the hospitals have a lot of latitude to craft their policies.
Got it. Well, speaking of strange things in hospital financial policies, let's take a look at the poll results. Yes. Well, I think most of you got it, that it's all of the above. Not all at one hospital, I should hasten to add, but clearly there are a lot of different dimensions. And when I look at this, the thing that strikes me is the last point that Paula made, that there is a fair degree of latitude and discretion in how hospitals craft their policies. So I think that means there's room for some degree of standardization based on public interest considerations. But, you know, I'm going to say something and we're going to move on to the next panel. Maybe we'll talk about it there, but maybe I'll leave a minute or two for Noam and Paula to react. But, you know, the question of the variability of policies, it really is very asymmetric how reasonable that is. If you're a patient, it's very unreasonable. It would be lovely to know that anywhere in Boston, that street or down the block, or anywhere in New England or anywhere in the country, I had a rough idea that there's a standard way of looking at this and a standard approach and a standard guideline, maybe regional because, you know, incomes vary. So that is very reasonable, but from the hospital side, it is not reasonable at all. Different hospitals have different financial realities. What they're able to do and still stay in business is going to be different. So we can't have a one size fits all. And I think that is a contradiction that we're going to have to resolve. Noam?
I mean, I think you're right. Clearly, there is going to be something that needs to be resolved. But I would step back and ask the question, what is the purpose of the hospital? The purpose of the hospital, I would argue, is to serve its patients. And obviously, the hospital has to keep its lights on. But I think the pendulum seems to have swung so far sometimes in terms of thinking about the sort of financial values of many of these institutions that it sometimes can make an institution forget that its ultimate responsibility is supposed to be caring for the people who come through its doors.
All right. Well, we only have a minute left, so this is lightning round question, Paula, you, and then maybe Noam can chime in. What about the rise? This is from the audience, I think. What about the rise of medical credit cards or hospitals offering third-party payment plans? Do you know anything about that?
I've seen some affiliations. There's a Florida hospital system that actually has integrated that as part of their billing and collection department. But it seems to be financed predominantly only by one company based out of the Midwest. It doesn't, from what I can tell, that's from the research I've done. So.
Mm-hmm. So we clearly hear anecdotes about it. I've been hearing rumblings. Noam, what have you been hearing? Anything?
Well, we did some research into this, and it's not uncommon. There are vendors in the market that do approach hospitals particularly, but also outpatient providers, dental, as well, to finance patients. Sometimes these are deferred interest products where people will sign up at no interest, and then if you miss a payment, it bounces up to 29, 30%. Sometimes they are more stable interest, 3, 7, 8, 12% interest. There was a recent study that suggested that this is not that common in hospitals, maybe just 10%. do this, but 10% on 5,000 is a lot, and it's a lot more common in some outpatient settings. And it should be noted, again, that many times this is essentially taking a medical debt problem and compounding it by adding an additional layer of debt on top of this. So, I mean, these are very problematic, I think, for a lot of reasons. It's one of the reasons why the Federal Consumer Financial Protection Bureau is looking for ways to regulate this. I think we may see some action on that front, depending on what happens in November.
Yeah, I mean, I think just personally, it is very troubling, kind of signal of additional financialization of kind of healthcare money flows. I mean, a lot of different parties are looking at it, and clearly, people want to sort of stick a spike into that flow and siphon some stuff off. So I won't go into Matt Taibbi's famous, almost Homeric epithet about the big banks around the time of the crash, but it is a concern. So I think we might just want to move on to solutions. Oh wait, I got another question from the audience, so let's take this before we move on. Have either of you looked at or been able to see whether hospitals in high-income neighborhoods or with a larger share of privately insured patients are more generous or less generous with regard to financial assistance?
So we did not do that analysis. But I'll share one observation which surprised us in the subset of, Paul, I'd be curious whether this matches with what you're seeing. We thought we did look at, for example, profit margins for hospitals, both not-for-profit and for-profit, and whether there was any correlation with different kinds of aggressive collections, financial aid. And there wasn't a lot of correlation. In fact, it was sort of all over the map. You had some, for example, HCA, the largest investor-owned hospital system in America, has a reputation of sort of being rapacious in the way that it doesn't sue its patients. Whereas you have, our Sisters of Charity, it's not a real name, but Catholic system, incredibly aggressive about the way it goes after patients. And so there didn't seem to be rhyme or reason actually in the way this was, the policies unfolded.
Yeah, well, I agree with you, Paula. Maybe I'll answer for you. I don't think we have enough data yet to really talk about this, but I'm hoping that certainly by the end of this project, we will have enough data to really look at this in a little more detail, because it speaks directly to that earlier question I'd posed about the variability. I mean, the variability on the hospital side, if it's justified by the hospital's financial condition, payer mix, et cetera, that is one thing. If it isn't, that's something else. And I think until we have the data, we don't really know, and we should just go where the data takes us, at least on that question. That's kind of my reaction. Paula, anything you want to add to that?
Yeah, we have other projects where you can use and these different data sets to overlap on top of this. But I think the main drive we have right now is just getting these policies, standardizing the data, and making sure that we can produce a really high quality data set at this point.
Yeah, great. Well, thank you. Thank you to both again. This has been a good discussion. Again, scratching the surface, and there's a lot more to come. So we have one more very exciting panel to join us. But before we do, let's take a quick stretch break, everybody. We've been sitting here. You can stretch. And while you get up and do that, I just want to share with you a little bit about an upcoming event. We'll have the full results of the 2024 Lown Hospitals Index for Social Responsibility available next month. So register now to find out which hospitals will be named the most socially responsible in the United States. And a special announcement for our New England audience members. On June 6th, we'll be honoring the 2024 recipient of the Bernard Lown Award for Social Responsibility. That is Dr. Lilia Cervantes from Denver, Colorado. There'll be a special dinner here in the Boston area. Tickets are going fast, so get yours now at lowninstitute.org/award. I'm really looking forward to meeting Dr. Cervantes. So, welcome to our next and final panel. This is titled Opportunities and Challenges for Change. So let me introduce them. Elisabeth Benjamin is Vice President of Health Initiatives at the Community Service Society of New York. Berneta Haynes is Senior Attorney at the National Consumer Law Center. Alex Spratt is Director of Commercial Sector Prices at Arnold Ventures. So welcome to all of you. So we've heard a lot in this past hour about the prevalence of debt, some of the drivers, a little bit about what we're seeing of hospital policies. So we'll get into all of that, but let's start with upstream solutions. And so let me just frame this as prevention is worth a pound of cure. How do we prevent medical debt from happening in the first place? We had a little inkling in the earlier conversations. Berneta, the floor is yours. What do you
Yeah, happy to jump on in. There are a range of upstream solutions to prevent medical debt in the first place, before it ever occurs. I think it's very important to start out by talking about the elephant in the room solution, which is single payer universal health care. I never pass up an opportunity to at least mention this very logical solution that the rest of the world has figured out. But we do need to enact some sort of universal publicly funded national single payer plan that's administered at the state and local levels with comprehensive lifetime benefits, dental, vision, mental health care, and so forth, hospice care. In the absence of universal health care, however, looking at the reality that we're playing within right now politically, we need to expand Medicaid in holdout states. Since lack of insurance is a key driver to medical debt, to even incurring medical debt. Lack of insurance and chronic illness are the two top causes of medical debt. So finding some sort of federal lever to expand Medicaid in the holdout states would go a long way towards reducing this problem. More viable solutions, though, right now that are much more tangible and within our grasp, particularly include improvements to the ACA, to the Affordable Care Act. Congress should improve the ACA by expanding comprehensive charity care requirements that would, among other things, broaden income eligibility to cover uninsured as well as insured people. Right now, insured folks are not necessarily included within charity care coverage. Also requiring providers to screen patients for charity care. Setting that in stone in the ACA would be a huge success. Requiring reasonable notice to patients before hospitals are able to take debt collection actions. Allowing patients to enforce state and federal financial assistance charity care laws in courts to hold violating hospitals accountable. So those are some huge ways to make changes to the ACA that are actually tangible solutions to prevent medical debt. States, meanwhile, in the absence of these federal solutions, states, meanwhile, should be finding ways to make similar improvements to their own state charity care requirements. So I'll stop there because there's a lot more that I could say, as you can tell.
Great. Well, we'll keep going. Upstream solutions, Alex, from where you sit, what would you say about those?
Sure. Thanks, Vikas. Thanks for having me. So agree with everything that has been said here, but really come from the perspective that in order to address medical debt, and this is how we enter the medical debt conversation, we really have to address the underlying price of care that we pay to hospitals and providers, particularly for the privately insured. Vikas did a very nice job talking about this earlier in today's conversation, but over the last, let's say 40 years, if not longer, we've seen rapid consolidation of our healthcare system, hospitals buying other hospitals, hospitals buying physicians, physicians buying physicians, plants buying physicians. And what that has meant is that there is increasing market power among providers and hospitals in this country that allows them to kind of leverage that power in negotiations with insurers and jack up their prices. Those prices are then have to be covered by someone. And ultimately, all of us here get left holding the bag in several different ways, whether that's through our out-of-pocket costs, our deductibles, our premiums, whether that's through wage reductions because our employers are increasingly having to pay more and more for our healthcare coverage and covering more of our premiums, or whether that's through the taxpayer dollars we spend to fund the government. And, you know, it is worth saying, I am not saying insurance companies are the be all end all, but they play a middleman role. Their profits are capped. They don't have a ton of incentive to lower these prices. And for the most part, prices are just passed on to consumers and patients. And so we've been left with a system, as we've talked about today, where, you know, patients are seeing more and more pressure in terms of deductibles and out-of-pocket costs. They're seeing higher and higher premiums. And so for us, as we think about the medical debt problem, are really thinking about how we address this underlying price of care. And so we might be thinking about things that make the price of care more transparent, thinking about how we address consolidation, some of those key drivers of high prices. And then we are thinking about things that kind of directly limit the prices. And that could be everything from capping what we're charging certain income groups. So as we've seen in the examples from Paula, super helpful maps that we just saw, there is quite a wide disparity in sort of the income levels and what's being capped in terms of financial assistance programs or free care. And so we are really actually just talking about capping the price of care, maybe by income level for the uninsured, depending on the type of hospital, et cetera. You have those types of solutions. You have solutions around banning or capping the price of facility fees. So your doctor gets purchased by a hospital and all of a sudden you have a new charge on your bill that really isn't for any type of new care. And so how do we address those types of underlying drivers really helps us get at our medical debt issue that we're talking about. And again, all of the solutions that have been discussed today are important and kind of fundamental first steps that we should be taking. But if we ultimately want to fix the affordability problem in this country, we have to go back to this core driver.
Thanks, Alex. I got so many questions for Berneta and you just on this issue of insurance companies, prices, payment mechanisms, but I'm going to bite my tongue and we'll hopefully get back to it. So upstream solutions, Elisabeth, you have a lot of deep experience on this issue of medical debt in New York. You've done amazing work. Your team has done amazing work. What's your perspective on the upstream side? I think you're on mute.
Excuse me, I'm a state-based advocate, so I have state-based solutions, and we have just in New York with an incredible campaign of partners with AARP, with NAACP, with Hispanic Federation. I mean, the list goes on, a huge, just an incredible coalition of 50 organizations. We've just worked the punch list of all the system, all the things that are in our system, our like debtor mindset system that really trip up patients. So the first thing we did is hospitals and medical providers had 6 years to sue people. So bills would rack up at a 9% interest rate. Let's move that statute of limitations down to 3 years. That 9% interest rate, that's, you know, and the interest rates for the last 20 years was only 2%. So we changed the consumer judgment interest rate to 2%. That was the next year. Hospitals could take liens on people's homes. Well, that's people's equity. How could we allow that to happen? Let's no more liens in medical debt cases. That was the third thing we did. Hospitals were garnishing wages. When we looked at whose wages were being garnished, they worked at, you know, really expensive, you know, they worked at TGIS and Walmart, like whose wages were being garnished. Goldman Sachs was not on the list of employers that we identified, got rid of wage garnishments. Next thing we saw was facility fees. We saw patients that were being charged facility fees for preventive care. Like that's supposed to be free. That was just an end run around the Affordable Care Act. We banned facility fees for all preventive care and put in a pretty onerous disclosure requirement where it had to be in 12.5 fonts 7 days in advance that a facility fee was going to be imposed. And then we also said, okay, medical providers and their collection agents should not threaten ruining someone's credit report. So we banned the practice following Colorado. I want to say Colorado was first, we were second, of the being able to report medical debt to the credit reporting agencies. So it's now impermissible for a provider to make the report, and it's impermissible for the credit reporting agency to report out a medical debt. So it's both in and out. That information no longer can go into the credit agencies and it can't come out. And then the last thing, our holy grail, was really to do what people have already been talking about, improving hospital financial assistance policies. We now in New York State will have one uniform application form. There will be no questions around asset tests. It will offer financial assistance up to 400% of poverty. Hospitals will be banned from suing anyone below 400% of poverty, and that burden of proof is on the hospital CFO to say that they made reasonable efforts to determine. We didn't get private right of action, Berneta, we tried. But it also says, and to Alexandra's point, the discounts are off of a Medicaid rate. So if it's free below 200%, between 200 and 300%, it's 10% of Medicaid is what someone would owe. And it's between 300 and 400% of federal poverty level, it'll be 20% of Medicaid, capped at 5% of someone's gross family income in a year. So lots of details there. I'm sorry to go through it, but I think it's incredibly important for states, advocates to get organized and work the punch list. It's just, and we had a whole organizing campaign, and we worked our systems in New York. It's a scrappy state, so you have to kind of fight hard, punch low, and eventually you can win even against the most powerful industry in our state, which is our healthcare industry.
Wow. Thank you. Thank you, Elisabeth. So before we go to a few questions we'd already prepared, I'm just going to circle back to a couple of things you all said. And specifically to you, Berneta, and you, Alex. So Berneta, you talked about the really upstream solution that, no one dare mention his name. It's like Voldemort, but I think you're right. That's a solution that clearly would have a lot of impact. But then you said, so if we're going to talk about viable things, and that implied more incremental things, the incremental viable things you talked about were all on the hospital side. And it just struck me, are we really sure there aren't incremental things we could be doing on the insurance side? Because, Alex, the consolidation that hospitals have undertaken in large measure has gone in tandem. I'm not going to say which came first, the chicken or the egg, but in tandem with consolidation of the big insurers and the sort of mega mergers at that level. And so I'm sure their view would be that we got to survive. We got to get big to survive, or we're going to be their lunch. And so, in that world, is it really the case that the insurers are merely middlemen? So start with you, Berneta, and then you, Alex.
Yeah, I will definitely reiterate, that big elephant in the room, single payer. And I have to always mention that because it's the common sense solution. But it isn't politically viable for us right now. We can make it politically viable, but that's going to take some work, right? But in terms of the viable solutions that I spent more time on, financial assistance, improving the ACA's requirements, a lot of that should be on the hospitals. This is not to say that insurance isn't important to tackle in this equation. We don't actually do much work around insurance issues at NCLC. And the one thing I will say, if we manage to pass some sort of, pie in the sky legislation where no deductible could be more than $500 a year, for instance, a lot of people still don't have $500 for an emergency. So even great insurance plans that have low deductibles like that are not going to be necessarily sufficient for a lot of low-income folks who really just need to be able to access charity care that these hospitals have to provide anyway to maintain their tax-exempt status. They need their feet held to the fire for that requirement.
And just one, well, I'm sorry, Berneta, I mean,
oh, no, you're good.
Just one important fact here, 75% of all medical debt is hospital debt. So let's get serious about, if you want to solve the problem, we're going to have to deal with hospital, I think, pricing and behavior. And that said, in New York, we're also doing some extraordinary work around trying to design a more equitable health insurance benefit. We're the first state in the country that will now ban any kind of cost sharing for insulin. And we're really proud of that. Medicare just moved to $35 a month. That's still, almost $1,000 a year for someone, right? That's a lot of money to come up with. So why would we ever have any deterrent for someone accessing insulin? Like, that just means more expensive healthcare later on if someone's rationing. We know that the biggest issue for adherence in medication is cost and cost sharing. So I think we really need to start thinking through health plan designs to get rid of any kind of cost sharing on any kind of medication for chronic conditions. Why would we do that? And there's an amazing study actually done by Blue Cross Blue Shield of Louisiana that showed when they got rid of cost sharing for insulin, hypertension, and like a little bundle of chronic conditions, they saved $71 per patient per month. They saved money. So I think we at the state level, perhaps, you know, obviously I'm a big believer in the laboratory of the states, should really start getting into insurance design. And I'm really proud that our marketplace is making movements to do that and is also trying to get rid of cost sharing for some of our qualified health plan products beyond insulin. And so it's really an exciting time to really start thinking through how health insurance is designed. And to me, that's sort of the next big thing now that we've won our holy grail on hospital financial aid.
Thank you, Elisabeth. So Alex, you know, to you, the same sort of set of questions. It seems to me that insurance design, as Elisabeth pointed out, it has to sort of be a part of the solution. I mean, otherwise, you know, we're in a world where, you know, as we said at the outset, you know, hospitals are put in this sort of moral bind in which they, in fact, have to provide the care. You know, many people, if not most, whether they say so or not, think of healthcare really as a human right. They just assume that that's something, you know, that's available. And hospitals are expected to live up to that. On the other hand, we treat healthcare as a commodity and hospitals as businesses. And in that equation, insurance companies and the insurance design has to be part of the solution. So I'm just curious what you think. Can we get to price changes without tackling the insurance side?
Yeah. And maybe one thing just to say on the single payer point, I think for us and for myself, in terms of kind of political feasibility, aren't necessarily in a place of going all the way to single payer, but we do very much support kind of rate caps for all hospital prices. I mentioned kind of rate caps by income level, but I think our ultimate kind of pie in the sky solution here from a feasibility perspective is really thinking about rate caps kind of across all hospital and physician services. And it is just worth saying, and I'm going to beat a dead horse a little bit here, we are paying egregiously high prices without getting much in return. We know the evidence, there's a wide body of evidence that really shows that hospital prices are set arbitrarily. We are not getting increases in quality or patient care as a result of higher prices. And there is quite a lot of fat in our system. And so just for example, RAND yesterday came out with this new data, RAND 5.0, if folks are interested, finding that we are basically paying 254%, so 2.5 times Medicare prices in the privately insured for hospital prices. If we were to limit that to just 2 times Medicare, so it's a slight cut, but it's not down to Medicare rates, for example, that would reduce premiums for Americans with private insurance by $900 billion over the next decade. That's huge for American families. And so I agree, right? I do think there are a lot of solutions that we could be thinking about on the insurance side. One, just very basic one that we think about quite often is when we are reducing these prices, how do we make sure those reductions are getting passed along to consumers and patients? How do we make sure those are getting passed along to employers, right? So there's a number of mechanisms. We've started to see this. For example, Colorado has a public option that is really focused on lowering premiums through kind of the lower prices mechanism. So how do we ensure that's getting passed along? There are policy solutions focused on insurer consolidation and insurer provider consolidation. And when that world gets muddy, what happens? Thinking particularly about some of the FTC and DOJ's new work, thinking about vertical consolidation and vertical integration between plans and providers. I expect with a lot of what we've been seeing with United and some of the other kind of data hacks, I'm going to start talking about things I don't know about in terms of internet security, but we've seen the kind of consequences of this massive consolidation across our system. We can change insurers' incentives for and their profit motives, thinking about medical loss ratios and things like that. So there are a host of kind of solutions, but to the points that have been already made on this, I mean, ultimately we have to kind of start with the hospitals, given the kind of egregious nature of the prices and kind of what that has meant output wise for folks in this country.
Can I respond to, can I respond to something that Alexandra said?
Just one,
Oh.
1 second, Elizabeth. Alex, I just wanted to follow up on one thing in what you said. I'm so glad you talked about the mechanism of the savings, because I know from the provider side, as a practicing clinician, you know, the idea, and we talk about low value care and reducing waste, and you know, the old saw is always one person's waste is another person's income. It would go down a lot better if there were confidence that those savings that are being generated from clinical waste are going to the right place. And that's kind of part of why I was posing this question. The changes in insurance design have to go in tandem with price and cost focus, because unless we do that, you got a whole, it's the classic circular firing squad, everybody shooting at each other. And in particular, we have a situation where I don't really want that to end up in the pockets of insurance executives who get a $10 million bonus at the end of the year. So I think, you know, it's fundamental. Sorry, Elizabeth.
No,
maybe-
oh, go ahead, Alex.
No, so I'm sorry, Elisabeth. I was gonna say, I totally agree with all that. I think it's also worth saying that when we take on these policy reforms, we get a lot of money saved from a taxpayer perspective, which allows the government to then reinvest in higher quality, much needed care, whether that's in the safety net system, whether that's in rural communities, whether that's in primary care, right? So if we can take some of this fat out of the system, it does allow us to do these other things to improve kind of care and access to care and quality of care and all of the things we all want for folks. So I'm sorry,
Yeah.
Elisabeth, to interrupt you.
Thanks.
I just
So
want,
yeah, go ahead.
is it okay? I just want to respond to one thing, that one policy solution Alex was talking about, which was all payer rate setting. So setting the hospital rates. New York was one of the last states to lose that. And in the wake of us going from having the state set the reimbursement rates from all hospitals to letting the market-based solution where every hospital was left to its own devices to negotiate with the carriers, we have lost almost a third of our hospital bed capacity in the state, which was a real problem in the pandemic. So we went from having 75,000 beds in 1997 to now we only have 55,000 beds left in New York State. And so, because why? Because certain hospitals, like 5 of them in Queens, were not as powerful as the Upper East Side's Bedpan Alley. And so all the market power was essentially consolidated in sort of, you know, very rich, affluent areas at the real cost of rural places, critical care hospitals, safety net hospitals. And so I think we really, I am a huge fan of all payer rate setting as, you know, a step to the path to what Berneta started us out with, which is, you know, we do need sort of a more rational, universal healthcare system. But I think that's, it's going to be hard to get it back. Like no one has an appetite in New York to go back to all payer rate setting, but I think we should. It's really hurting patients. And I think that's a side effect that we aren't talking about, is having fewer hospitals is a real problem for people who need the care.
Yeah, well,
Can I just say,
what we see repeatedly is a lot of the most socially responsible hospitals in our metric are often the most financially stressed, and some of their viability is threatened. So Berneta, you have the floor, and while you're there, you know, Elisabeth talked about New York in particular. What are you seeing in other states as well?
Yeah. On the hospital point, right before I get to like what kinds of successes we're seeing in other states, because the states are leading the charge on improving this particularly problematic situation we have. I think one reason to really focus on hospitals, why it's really important to focus on hospitals, is because from a rhetoric standpoint, it's more persuasive. You have institutions here that are often nonprofit, right? Many of our hospitals in this country are nonprofit. Only like 2 states have more for-profit than nonprofit hospitals. There's Texas and Nevada, I believe. So you have this nonprofit entity that has a tax exemption because they're supposed to be providing a service to the community. I think it is easier to message to people the problems of that kind of entity not providing charity care and financial assistance to people who need it. I think it is easier to say, look at this institution that's not paying taxes. They're supposed to be helping us, and they're not even providing charity care. Not to mention, we've seen reports out of places like Maryland from Nurses United that showed the record revenues hospitals were pulling in while still suing patients for bills as low as $1,500, $900, people losing their homes, and wage garnishment happening because of $900 bills owed to a hospital that's raking in billions in revenue. A hospital suing these patients for amounts that don't even come up to 1% of their overall, income stream and revenue. So I think it's persuasive, the messaging that we can do around hospitals and the improvements that are needed there. It's a little trickier with insurance issues, right? The other thing, getting to what states are doing, states are leading the charge in terms of tackling issues around medical debt. We have states like Arizona and Colorado capping interest rates on medical debt at 3%. Delaware recently passed a law prohibiting interest and late fees. We are seeing prohibitions and or limiting of aggressive debt collection actions. States that are prohibiting liens against homes, like New York, garnishment of wages, like New York, and seizure of bank accounts, prohibiting civil arrest warrants for medical debt. I think most people are really surprised to find out that that's a possibility when they are summoned to court and don't appear, right? So some states, particularly New York and Maryland, have taken a lot of steps in that respect to put some limitations or prohibitions around aggressive debt collection. Maryland this year is trying to extend their limitation on liens against homes to providers, not just hospitals as well. Banning medical debt from credit reports, we have states really taking the lead. There, Colorado in 2023 passed a law banning medical debt from credit reports. Connecticut, I think it's Connecticut, just did it a couple of days ago or a week ago. We're seeing improvements to financial assistance programs where states are broadening income eligibility and even requiring screening upfront. One of the main problems with financial assistance is that a lot of people who would qualify have no idea it even exists. So requiring screening upfront is a huge way to make sure that hospitals are actually abiding by the Affordable Care Act's requirements to provide financial assistance. Oregon passed a law in 2023 to require screening or presumptive eligibility for patients owing $500 or more. Illinois did the same thing in 2023, standardizing their procedure for screening. Maryland now requires hospitals to reimburse patients who paid for care, but who it is determined would have qualified for financial assistance had they made it available at the time. And then lastly, I'll say Vermont in 2022 made a debt collection activity against a patient whom the collector knew or should have known qualified for financial assistance, an unfair and deceptive practice that entitles the patient to remedies. The patient can sue that debt collector. So the states are really, really leading the charge in terms of tackling this medical debt crisis. There's so much more that can be happening at the federal level, but I think we definitely need to use our leverage at the state level to make the change possible that we want to see happen.
Thank you. Speaking of leverage at the state level, I want to ask a question. We noticed, before I do, we noticed at the federal level, Senator Sanders, Bernie Sanders, and others introduced a bill just last week. We haven't had a chance to dive into it in detail, but it purports to eliminate at least existing medical debt within 2 years. So I think we'll all have to take a look at that and see, is it feasible? Is this just a messaging bill, as they like to say on Capitol Hill? But regarding leveraging what's happening at the states, Elisabeth, your organization, I think, really was exemplary in first gathering data and then deploying the data for policy change. Can you talk just a little bit, a couple minutes, on how that actually worked and why that was successful?
Yeah, it's not for the faint of heart. Let me put it that way. In New York, it's the 4th largest state in the country. So we have about 200 and I think 18 hospitals in our state. So we literally went and searched by the hospital name in every single county, all 62 county civil court databases for the hospitals suing patients. And then we had to open up each hospital debt file to make sure they almost all were, but it would make sure they were, to validate they were medical debt cases. And then we, our policy team, oh, by the way, all of this was generated because we run a consumer assistance program. And in 2019, under the Affordable Care Act in 2019, we saw a 64% spike in medical debt cases. And we were like, what's going on? suddenly the hospitals were like starting to sue and do all these aggressive collection actions. And so the way we figured out what was going on is we decided to start searching by hospital name in all these databases. And then we started issuing the reports. And it was called Discharge into Debt. It's on the Community Service Society website. And I think we're up to like 7 of them now. The first one we did was just looking at 26 counties because, you know, it was kind of a lot of work, I have to tell you. And we found that the median amount of these lawsuits were for nothing. They were for $1,900. So hospitals were nonprofit charities were suing people for $1,900. And Sara Rosenbaum said something so important. I think it kind of went by. Why would they do that? All these hospitals have at least hundreds and hundreds of millions of dollars in revenue, some billions of dollars in revenue. So why sue someone for $1,900? No hospital's making its margin on these $1,900 cases. It's to deter people from coming back. That's why they're suing people. They don't want them to come back. They don't want these patients to ever come back and be so stupid to come into their hospitals and, you know, hope that they can get care. It's really down to that, because there is no business case for suing patients except to deter unwanted patients from coming in. So we did that. We then looked at, did some deep dives like in Albany County on racial disparities in medical debt, and then kind of mapped it along the census data to show that, you know, the St. Peter's Health System, for example, was suing in some, and like sometimes like 25, I can't remember the exact percentage, something like 25% of their cases were in majority minority zip codes or disproportionate. Others were like over 50% and in overrepresented minority zip codes. So it was, or minoritized zip codes. I don't want to, you know, so anyway, it was just really extreme. We showed another system was suing people throughout the pandemic, and we worked with a Times reporter, Pulitzer Prize, amazing reporter, Brian Rosenthal. And unfortunately, our timing wasn't great. It was the same day as January 6th. So we had a very small like inch on the front page of the New York Times with Brian on, you know, Northwell's collection practices during the pandemic. We did another one just on the liens issue. We did another one just on the wage. So anyway, so it's not for the faint of heart, but it really was an important strategy. And the other thing I want to do is we didn't just go to write these reports and go to the press, although we did do that, is we really tried to engage with hospitals. And so as a recovering litigator, we would, for the hospitals who are suing the most, we would do a random sample of their cases and then write letters to their CFOs and CEOs saying, hey, we don't know if you are even aware of what's going on, because a lot of times it's like my cousin Vinny's lawyer that just happens to have a friendship with the CFO or some board member or whoever knows how these collection attorneys come into the hospital. And some of these CFOs and CEOs really didn't know what was being done in their name. So we would write these very comprehensive letters analyzing the data about how much hospital financial assistance they were actually giving out compared to what they were making in terms of these lawsuits, where they were suing people. And I thought we had some really interesting conversations along the way after writing some of those letters as too.
Thank you very much.
Sure. Sorry, I went on a little too long. It was a whole like strategy.
Well, it's a huge sort of a marathon.
Not to mention the electoral strategy. We had a strategy around that, and our incredible partners in the campaign were really amazing.
So we have some audience questions, and we're really in the tail end of an incredible conversation. Here's one that really speaks a little bit to our back and forth earlier. Health systems provide care without any assurance that we'll get paid by commercial insurers. We spend so much effort trying to get paid while payers sit on the premiums they've already been paid. This is what I was talking about. Is anyone talking at all about requiring all payers being not-for-profit or capping their profits like we do with utilities? I would slot this into that somewhere in between a full single-payer system and the status quo, somewhere in between. Can we make changes at that level? We sort of talked about this, but maybe another go round if you want to. If you don't, that you can pass. Alex, any thoughts?
Sure. I mean, one thing is we're saying is, for better or worse, insurance companies, put aside whether it's a functioning system, their profits are currently capped. It's what's called medical loss ratio. It depends on what market you're in, at what percentage we're talking about, but insurance companies are required to basically use 85% or 80% or 70, again, depends on the market, some percentage, a high percentage of premium dollars on medical services. And so their profits ostensibly are capped at, whether that's the 15% or depending again on the market. There are flaws within that system. I am not going to say there are not. And so I think there are policy solutions for thinking about how do we improve MLR? How do we strengthen it? How do we make sure it's enforced appropriately? Things like that, that could better get at this issue and help address some of these things. That being said, that mechanism does exist already. And so for us, again, takes us back to this underlying problem. Again, thinking about how we pass these savings on when we lower prices to patients and employers, et cetera. But it is worth saying that some of these mechanisms do exist. And, you know, there are a number of ways they're abused.
We think
Thank
there
you.
should be a hospital loss
Sorry,
ratio.
Elizabeth.
Oh.
Berneta, do you wanna react to that? Do you have any thoughts on this sort of intermediate level of insurance regulation?
Yeah, I mean, I think it's interesting because we have like versions of that already exist. Like, I mean, Medicare is like that to some extent, and it's not nonprofit, but it's government run. The VA system, I'm constantly jealous of my husband who never has to worry about a medical bill. So we have versions of that sort of intermediary that already exist, really.
Yeah.
They need some fine tuning. Each of those do. They have their problems and limitations, but they are miles ahead of, you know, having to deal with private insurance.
So this is a question, you know, for all of you, but maybe Elisabeth wants to take it first. But that is, you know, there's a set of emerging philanthropic efforts to relieve debt by buying certain kinds of debt. And I think we all know that certainly one of the groups that has been most prominent and visible on this has been what was RIP Medical Debt, Ruth's organization, Undue Medical Debt. The question is, do these efforts work for patients? But is there any risk to hospitals from these? Which isn't, I hadn't thought about that, but maybe there is. Elisabeth, your thoughts?
Sure. Well, Jerry Ashton's on, the founder of RIP Medical Debt's on this chat stream. So, you know, we worked closely with Jerry back in the founding days and really appreciated his passion and what I really think was the project, which was to draw attention to the harm of medical debt. That said, the model is not ideal for patients. And I think we have to be realistic and look at I mean, I really give props to RIP Medical Debt or Undue Debt, whatever they're called now, for getting the research out there and working with the National Bureau of Economic Research. And what they found was relieving debt years later doesn't help anyone. It, in fact, made them feel worse about themselves. It actually had a mental health harm. And so I think that's why our approach in New York, and I think the National Consumer Law Center has been really working and supporting that, is to get medical debt relieved at point of service. That's through hospital financial assistance right up front, so that a patient is treated with respect, knows that they can come back for care because they can get a discount, a fair discount, following prescribed rules that are set by the state or that hospital. And that's the right approach. We have just seen that RIP Medical Debt has not, you know, we've been disappointed that they've just been going to hospitals and making these deals, but not, and sort of improving the hospital's financial business situation so the hospital can go out and get loans or whatever. It improves the hospital's books, but in exchange, they haven't required the hospitals to reform their own hospital financial assistance policies. They haven't really, you know, and made a real, you know, contract to improve the patient experience for patients. They're just offloading old debt the hospital was never going to collect anyway. And so, you know, I don't mean to be harsh, but I really appreciate Jerry for drawing attention to the issue. And of course, the individual people that get a golden ticket, some seem to be pleased, but I was really disturbed by the National Economic Bureau research saying that a lot of people felt horrible after having that experience. And that was a statistically significant sample.
Yeah.
And so we have to, you know, read the data and incorporate it.
Yeah, thank you, Elisabeth. We saw that research report as well, and it certainly is food for thought. Sorry, did I interrupt?
Yeah,
Berneta?
no, I was just going to say that, we are like extremely appreciative of what Undue Medical Debt does, because I can, and just in conversations I've had with Eva and whatnot, one thing that they always make sure to do when they go into these conversations with city lawmakers and so forth is to bring up those systemic changes that are necessary in addition to medical debt cancellation. And the thing is, right now, medical debt is this like shiny object that medical debt cancellation is like this shiny object that a lot of lawmakers are interested in, so they can use it for political gain. So if you can use that to open a door to conversations with them about systemic long-term changes, I mean, it's a great strategy in my opinion. And I think it is bringing more of those systemic changes to the conversation that these lawmakers wouldn't have cared about or been thinking about before. One thing I'll say is that I've always said that you could cancel all medical debt today and it still won't stop the medical debt of tomorrow. And it's very similar to the student loan crisis. And I'm going to speak here as a millennial. I firmly, firmly believe that you have to have the systemic long-term change and the immediate relief at the same time. You need medical debt cancellation and significant improvement to financial assistance, Medicaid expansion, all that stuff at the same time, just like you would need student loan cancellation and free public university passed at the same time to really make a dent in these problems. So I really strongly appreciate what Undue Medical Debt is doing by at least bringing up those systemic changes in the conversations. We need to build upon what they're doing, in my opinion, to make sure that it has lasting teeth and effect.
Thank you, Berneta. Boy, time has really gone by. We only have time for another one, maybe two questions. So let me get right at it. Before I do, I just want to make a distinction, which may be subtle, but there's a difference in my mind between buying debt and canceling debt. And I think it's sort of interesting maybe to explore that at some point. Buying debt, in my mind, legitimates it in a certain way that maybe shouldn't be so. Question, last week legislation was introduced that creates a program to cancel all existing patient debt and block creditors from collecting past medical bills. I'm not sure if this is the same as the Senator Sanders legislation or not, but the questioner asks, if that passes, who pays the providers? Where does the money come from? How will that not bankrupt the country? Any of you want to look at that?
I'm coming off mute, having not read the legislation, so I don't know if there's a specific mechanism in the legislation. But a lot of times, kind of uncompensated debt, whether it's Medicare bad debt, whether it's kind of charity care, things like that, but essentially when the medical bill is not paid, that's often provided back to the hospital in the form of a tax break. And so 54, I believe, %, something like that, 2/3 maybe closer, of hospitals are nonprofits. They are reaping kind of huge dollars back in terms of tax breaks. And that is in exchange for providing charity care or things like that. And so in a system that worked functionally, the tax breaks would be commensurate with what's being provided in charity care. But we both know that charity care isn't being provided. They're getting the tax break anyways. And then debt is maybe going off into the ether. Maybe it's being bought back on, some cents on the dollar. Maybe it's never getting paid. And so there are just like a number of kind of incentives and mechanisms along the way that are broken. But at the end of the day, we, the taxpayer, are getting kind of gouged in different ways because of these cycles. And so again, like that's not like I haven't read the legislation, so I want to be very clear and caveat my comments. I don't know if it makes some caveat for that, but in some ways, the debt that hospitals are claiming, they are being compensated for, and they might be taking people to court or putting liens on houses or garnishing wages or anything, all those things anyways.
Yeah. Well, got to read the legislation. My reaction to the question is, at least my sense is that the total volume, just from a sort of cash flow point of view of, the income lost due to the debt is probably not sufficient. I mean, it's going to depend obviously on the operating leverage of every individual hospital, but for most, I don't think it's going to be enough to sort of bankrupt the country as the questioner poses, or bankrupt even the healthcare system. It might put a few hospitals in jeopardy, and that's worth looking at. Last question, and then we really got to go. Interesting one, because I don't know the answer. I don't know that any of you do, but if you do other countries have medical debt the way we do? And how do they manage it and treat it? I
No,
can
they
say
do not.
in India, I can tell you the Indian system is very much like the US system. Medical care is a big driver of poverty in India. But I don't know about other countries in the world.
Not
Anybody
in the
else?
OECD countries, really.
Yeah,
It's-
exactly.
You're exactly right, because I worked in India for several years.
Yeah.
Same, similar market-driven
Mhm.
system.
Yeah.
Mhm.
Wow.
Yeah, and even in those countries, not India, that don't have like a single payer or universal system, the cost of healthcare has a tendency to be lower. You see that in countries like Mexico and so forth. But yeah, medical debt. It feels uniquely American. We know that it's not entirely uniquely American, but I do think the astronomical amounts of medical debt that we see here might be uniquely American, like $300,000 for delivering a baby, that kind of thing.
Yeah.
So yeah.
Well, my Lord, thank you to all of our panelists. This has been terrific. 2 hours is up. I can't believe it. And thank you to the entire audience for joining us for this state of medical debt in the United States. We've seen how medical debt reflects a lot of the systemic problems in our healthcare system: uneven coverage, skyrocketing prices, and maybe a forceful focus on maximizing revenue. I would say, and I think it's fair to say, there's not just one driver. So I don't think there'll be one simple silver bullet solution. But it's really clear that we all need to be involved if we are going to change this and for change to happen. It's also clear this is a mammoth problem, and it's a mammoth problem that's seriously impairing the mental health, the physical health, and really, I would dare say, the productivity of the country. So here at the Lown Institute, as you heard, we're halfway through this project. We're going to continue this project, and we'll have more data coming in the coming year. But I also want to issue an invitation to everybody, both all the panelists here and everyone in the audience, to keep this dialogue going. We're more than interested in working with and talking to any and every organization that is interested in tackling this problem. We'd love to work with you in the coming year to work through how we might do things that would move the needle. So before we go, again, a big hearty thank you to all of our amazing guests. I would love to have an afternoon with each of them: Noam Levey, Edmonds, Christopher Goodman, Sara Rosenbaum, Ruth Landé, Paula Smith, Elisabeth Benjamin, Berneta Haynes, and Alex Spratt. Thank you all so much. Make sure you get all of our event updates and data releases and free blog posts and curated news by subscribing to the Lown Weekly, our weekly newsletter. Thank you all for tuning in today. We look forward to seeing you at our next event.